Welcome everyone. Welcome to this, our second IPWSO Leadership Echo. So it's my privilege now to introduce Nick Feiner. Nick is a Senior Principal Clinical Scientist in Global Medical Affairs, specialising in obesity at Novo Nordisk, which, as most of you know, is a pharmaceutical company making and developing anti-obesity medication, among other things. He is the Honorary Clinical Professor in the National Centre for Cardiovascular Prevention and Outcomes within the Institute of Cardiovascular Science at the University College of London. Nick chairs the World Obesity Clinical Care Unit. He chaired the unit in 2015, developing the SCOPE educational program. He is also an editor-in-chief of Clinical Obesity and has worked with Pfizer as a compound investigator and as a speaker in their medical educational program. Nick today is going to share his research on virtual clinics in the COVID era and beyond. Nick, I invite you to share your screen and talk to us about
Thanks very
virtual
much
clinic.
Indeed, James. And so perhaps the most important thing that you didn't mention in my biography is that Tony Holland and I were both at medical school together, and I suspect that's why I'm here today. We have collaborated ever since. When Tony asked me to give a talk at this ECHO meeting, I thought that what I would approach was the really big change that is happening at the moment in terms of how care is being delivered. And the background to this is that, in fact, at Novo Nordisk, and I'm sure other companies have been doing this, and I know that other healthcare systems have been doing this, is the development of trying to deliver care in a virtual environment rather than in a face-to-face environment. And I think that these were trends that were happening even before COVID, but of course, COVID has accelerated this process enormously. So my area of interest is particularly in obesity. And of course, there is a huge global prevalence of obesity, which in itself is a challenge as to how we can deliver effective care to these people who are living with obesity. And of course, we now have this growing global pandemic of COVID, and we know that the two actually have an interaction, which is why perhaps things have accelerated. Sorry, just a bit of technology problems here. I thought I would just start off by saying that, of course, while we know that diabetes is a major risk for severity of illness should you catch COVID, at the moment there is no data that firmly shows that people with diabetes are more likely to get COVID than the general population. Of course, if you have type 1 diabetes, which is not obviously the type of diabetes associated with Prader-Willi syndrome, if you become ill, then again, the severity of the illness may be increased through problems such as ketoacidosis. What we know is that people living with obesity are experiencing a major impact from COVID-19 on their everyday life and their treatment. These are data from surveys carried out by the World Obesity Federation, and we know that weight loss programs and interventions such as surgery are being curtailed. We know that measures of lockdown to either prevent COVID infections spreading, or if you have COVID, means enforced sedentariness and immobility. And this also impacts on the quality of the diet. And there is the growing evidence of the psychological toll that such self-isolation imposes. This is a recent report from Public Health England about children and young persons, as well as adults, living with overweight and obesity. And what they found was that such people are reporting major concerns about the increased risks if they develop COVID infection, that they have, as I've mentioned already, had reduced access to weight management. There is a growing use of food to manage emotional upsets of being locked down, and that health-related behaviors are harder to maintain in this setting. So that was, in a sense, by way of introduction, because of course what we know is that the pandemic is having major impacts on how care can be delivered. These are some recent, if you like, figures or concepts from the United States, showing that, of course, the advantage of moving towards virtual or telehealth are sort of listed here, that of course there are no geographic restrictions. It doesn't matter where the virtual care is being delivered from, so the originating site becomes irrelevant to a degree. Obviously, time zone shifts become a problem. Of course, audio-visual telephone visits are freely available, as well as telephone-only visits. There is, of course, the issue about how a new patient can be assessed. And I think in most countries, these are the one aspect of face-to-face consultations that are still being allowed. The last 3 or 4 points are very USA specific, and they relate to the fact that there is now a move to allow reimbursement for providing care in a virtual health setting. And there are also changes to the, if you like, insurance aspects of doctors who are delivering care in this way. And so what we sort of have known in terms of the traditional models of healthcare are sort of really changing to what we now know is that we are seeing physically distanced clinics, the impact of the link or the consultation between the patient and carers involves masks, gloves, face shields, no physical contact, sanitizing rooms. So the environment has changed dramatically. And while some of these aspects will, of course, go once the COVID epidemic has been brought under control, I think many of the aspects of virtual care will continue to be the basis of medicine. And it's within this, if you like, context of an ECHO meeting that it does seem to me that you, as leaders in the field of delivering and ensuring that people with Prader-Willi syndrome get access to care, if you like, are at the forefront, perhaps, of making sure that the development of virtual care is molded according to the needs of the people that you represent. Of course, one of the things is that people have been concerned that both either doctors or patients will find it, a worry not to have a face-to-face consultation. And this is a survey. It's a big survey, 150,000 people. And the first question was, how worried are patients going to be about maintaining their health through ongoing medical care, being able to see a doctor? And you'll see that there are 20% who are worried or very worried. They are also worried about going for a face-to-face meeting. So the second question was in response to the outbreak, how worried do patients feel about going to the doctor's office for necessary care? And you'll see that 40% extremely worried or worried about having a face-to-face consultation. So these concerns are there. In the background, of course, there has already been a big increase in telemedicine, and it's become a very major market, not just for healthcare systems, particularly in those countries where there is a state-run healthcare system, but it's become a big market for commercial companies to step in and offer remote care. Just a few definitions. Of course, we're used to electronic medical records in many countries, and these have been available and are a great help for the doctor in bringing up information. But this is, of course, not telehealth. Telehealth or telemedicine involves information and technologies, electronic communications to support remote clinical healthcare services. But I think what we really need to be moving to is this concept of virtual care that goes beyond just telehealth or telemedicine, that encompasses telemedicine and all of the other technologies, but for purposes of other than just diagnosis or treatment, but providing support, providing information, and providing ongoing care and treatment. So this concept of virtual care is, if you like, more holistic than just telemedicine as a virtual platform for a consultation. And this is posing, I think, challenges and learning on how we have to adopt the care that we would like to give to this new environment. So just going back to here, the specifics of telehealth, there is good information that consumers like it. They find that it's helpful in terms of decreasing hospitalization, and medication adherence is easier. And there are also, of course, as I've already mentioned several times, these risk reductions. There is also the challenges, if you like, of connectivity. And there will obviously be a return in part to face-to-face meetings. But I think that we can be reassured that over these virtual platforms, carers and health professionals and their clients or patients can actually recognize each other's emotions. Empathy can be communicated, and perhaps most importantly, for conditions such as Prader-Willi syndrome, team communication can be improved enormously. There is an enormous potential benefit from improving access to care. And this is something that I think I really want to emphasize, because of course, particularly for rare diseases where there are very few centers, maybe only 2 or 3 in some countries at the most, where patients with Prader-Willi syndrome can access specialist care, telehealth, telemedicine, and virtual care offers huge possibilities for engagement with professionals. And of course, there is the efficiency of not having to travel, give up a work day for parents to accompany their child, or for the costs of doing that. The challenge for doctors is that most of them have MD degrees and not IT degrees. And I think, we all experience the need to unmute or mute of the communication problems when our bandwidth isn't enough. But I think these problems are getting easier. I think, I don't want to go into the technology, but I think we do need to think about, if we're going to develop these systems, are we going to use a web-based system? Is the platform going to be secure so that people can't access the medical records? I think we have to recognize that for many of our patients, they will be accessing on a smartphone, not necessarily even on a tablet or a computer. So our screens need to be aware of the fact that many people will have a very small, just a telephone screen. And of course, we need to make sure that the platform is user-friendly. I think we also need to learn how to communicate, because we need to be sure that when we give a message to our patient or we receive a message from the patient, that we need to be sure that that message has been received. And if you like, that will involve that we slow down that process of communication, making sure that when we do talk to each other, that the messages have been received. And so, you know, when you've been on these platforms, you will be aware that people will at times break in and say, I just want to check that you followed what I was saying. So this is the program that Novo Nordisk is running to help clinicians set up virtual obesity clinics. These are not specifically aimed at either pediatricians or to people providing care to people with Prader-Willi syndrome. But it is a program, and if anybody's interested in possibly gaining access, let me know. But of course, what virtual care is doing is taking us out of our element. So the patient normally has to leave home, drive to the clinic, check in, sit in a waiting room, then go into another room and see the doctor. And that, of course, is changing. And one of the advantages from the physician's point of view and also the patient's point of view is that it can actually take us out of this clinical environment into the patient's home. So, for example, if we wanted to see what the cooking facilities were, or if our patient would like us to, if you like, give a quick dietary check on the things that they've bought and are on in their fridge, those sort of things can be readily done. And so there are big opportunities for, I think, changing the way in which we work. I think I'll skip over this slide just for time because this was, sorry. This was just the people who had joined our program, showing that many of these people had already started, and that the majority, of course, was still feeling this lack of personal connection, and that's the big challenge that needs overcoming. However, this is a survey again from the UK or the English National Health Service. And they did a survey of patients saying, would you be interested in having an online consultation with your primary care physician or other healthcare professionals? And 2/3 of them said that they would be. You'll see that not many already said their practice was providing this, and it was a minority who said they would not be interested. Coming back to the commercial side of things, you'll see that that has already started in England with people accessing private providers. So, what are the keys to success? Well, somebody, not myself, has coined the 5 E's, that there needs to be the patient and team experience of working in this environment. We need to be sure that we can engage with our patients and provide them with the skills and education that they need. But most importantly, we need to empower our patients to make use of the environment. And from the provider's point of view, we need to make sure that this is done efficiently. For those of you who may be interested, and this is not in the slides that were pre-circulated, this again comes from the National Health Service in England, and it's an implementation toolkit that they have developed for online consultations in primary care. Note the aims: to focus on people, not technology, to share good practice, and that's one of the roles for, I think, this ECHO initiative. Describe what will be the success factors. Help practices build connections with peers, and then there are ways of supporting progress. So there is a lot of information out there already as to how one can go about driving this initiative. And I've just taken an example as to how virtual clinics are being developed for integrating care for patients living with diabetes. And this is an example from the southwest of England on virtual clinics which can involve case discussions between a diabetes specialist and primary care clinicians who may be caring for patients with diabetes, but are clearly not themselves specialists. And I think this is a model that is ideally suited to the situation of providing virtual care to people with Prader-Willi syndrome. You'll see that these virtual clinics here described can provide time for teaching. They can cover specific topics. And they can bring together a multidisciplinary team. Here for diabetes, the practice nurse, nurse practitioners, trainees, practice managers. In addition, there can be case discussions in this virtual multidisciplinary team. Again, for example, in diabetes, talking about patients with poor blood glucose control, with foot problems, patients who may be housebound with diabetes. So these are techniques and these are services which are being developed for diabetes. And I think this is an opportunity for services for people with Prader-Willi syndrome to be developed. And I'll just finish by saying that if we look at the recent guidelines on the multidisciplinary care for Prader-Willi syndrome, you can see here that highlighted was not just the lack of reimbursement, but more importantly, the lack of infrastructure to provide these services. And I would like to suggest that in developing these infrastructures, you should be thinking very firmly about the potential of developing such virtual networks and access to these virtual care services. So, I'm not going to go into the laboratory checklists and the diagnostic and so on, because I think actually to a certain extent, these are not the challenge. What I would like to do is to talk perhaps about what people may perceive as the most challenging, the medical evaluation. Here are the recommended medical evaluations for adolescents and adults. I'm not going to read through them, but this is just my personal sort of view that if we look at these, the ones I've colored in green, I don't think are difficult to provide through a virtual setting. The ones in orange are clearly harder. Cardiovascular examinations are challenging, but with the availability of a variety of devices which are not expensive for people to have at home, certainly blood pressure can be measured. I have a watch that measures my heart rate and will even do an electrocardiogram. So some of these are challenging and will require face-to-face, but you'll see that the majority are, I think, not difficult to provide in a virtual environment. Here were the recommendations on anticipating problems in adolescents and adults with Prader-Willi syndrome. And again, I've sort of colored in green that I think many, if not most of these, can be equally effectively delivered in a virtual setting, particularly if it is in the context of a multidisciplinary team. So I will end at that point by concluding that I think that we need to be sure that we can remotely acquire sufficient data to make care decisions for patients. And this can be challenging. And of course, it may require collaborative pre-visit planning with our patients. I think giving patients the option for remote patient monitoring can help move virtual visits into a more efficient and effective path. And I would like to suggest that virtual care, and this is certainly our experience with people seeking treatment for their obesity, that it can actually make people more comfortable and remove some of the psychological barriers, terrors, and fears of face-to-face consultations in an environment, a hospital clinic, that is not the same as doing something from your own home and your own surroundings. Shared decision-making, which is so important to chronic care, will involve slowing the process down to understand, knowledge, empathize with the patient, and make sure that messages are being received in both directions. And I think if we're going to move into this virtual care model, we need to ensure that the patient experience is going to be perceived as positive, supportive, and engaging. I've given some further reading in these notes here, and with that, I will stop sharing my screen, and I hope I've left a little bit of time for discussion or questions.